All right, so hello and welcome to today's webinar focused on improving access to healthcare and public health services for uninsured migrants in Ontario. My name is Rebecca Sheff. I'm a knowledge translation specialist at the National Collaborating Centre for Determinants of Health, or NCCDH for short, and I'll be hosting the webinar today. I'm speaking to you from Toronto, the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. At the NCCDH, we support the Canadian public health community to advance health equity. We're one of 6 national collaborating centres for public health. We're funded by the Public Health Agency of Canada, and we're hosted by St. Francis Xavier University. And I'm so glad to be joined by my co-presenters, Shazeen Suleiman, Nisha Kansal, and Kara Hansel. They've all been doing work in the area of uninsured populations for years, and I've had the pleasure of working with all of them for, I think, like 7 years now, Shazeen probably. And my colleague Carolyn Boston is providing tech support and moderating the chat box. So like I said, please introduce yourself in the chat box if you're comfortable, and you can use the Q&A box throughout the presentation to add in your questions. We'll have time at the end and a bit in the middle to answer some questions. Okay, so the NCCDH is located in Mi'kma'ki, the traditional and unceded territory of the Mi'kmaq people. This territory is covered by the Treaties of Peace and Friendship, which recognize Mi'kmaq and Wolastoqiyik Maliseet title and establish the rules to what is to be an ongoing relationship between nations. And at the time that treaty was signed, slavery was still legal in what is now known as Canada. It was only completely abolished in 1834. So I want to recognize the resistance of Indigenous, Black, and Afro-Indigenous peoples in the face of continued colonialism and racism. All right, we want to hear a bit about you, see who's in the room. So to start off with, what province or territory do you work in? So we're using Slido throughout the presentation. You can go to slido.com and add that code, or you can scan that QR code with your phone. And, oh, we have our first response. Okay. So I'm seeing majority Ontario. I'm not surprised given the focus, but also BC, Alberta, Quebec. Okay. I'm going to keep us moving. Thank you for participating. It's great to have everyone here. So what best describes your role? We have community developer, consultant, director, educator, a number of different options. It's always cool to see where people are coming from the public health and health system. Okay, so public health nurses have a big presence. Health promoters, we have another category. And thank you, I'm glad people are introducing themselves in the chat too. We have students, welcome, policy analysts. We have some head of organizations. Oh, okay, sorry, I moved ahead. Let's see if there's any other. Okay, educators, managers, knowledge brokers, community developers, epidemiologists, medical officers of health, nutritionists, dietitians. Okay, a nice big range of folks, but public health nurses are in the lead. Okay, so thank you. I'm going to, again, move us ahead. Thanks for being here. I'm just going to put this webinar today in context. So In August, we released the Migrant Health Issue Brief. It brings together evidence about how a lack of permanent immigration status impacts the determinants of health and health outcomes for migrants living in Canada. And we did this because we were receiving questions from the field. We knew through partnerships that there were barriers, continued to be barriers to service and health for migrants. And there really wasn't a resource like this in Canada for the health and public health sector. We then had a webinar in August to launch that brief, and we're joined by Hassan from the Migrant Workers Alliance for Change. That recording is available. You can scan these QR codes to find the issue brief and that webinar. And so that brings us to today. We've actually done a version of this presentation at a couple conferences, and participants found it really helpful. So we want to make it more broadly available through a webinar. Given that healthcare and public health services can vary so much by province and territory, I think there's value in having something that focuses on a specific province. So we hope that for people in Ontario, you can get some really tangible information and strategies you can put right into practice. For people outside Ontario, hopefully this is an opportunity for exchange. You can learn from the Ontario context, and we'd love to hear more about your context, so you can use the chat to add your reflections throughout the webinar. For what you can expect today, I'll provide a brief introduction about why people are uninsured in Ontario and what this means for their health. Next, you'll hear from Shazeen Suleiman, who is a midwife at the South Riverdale Community Health Center, and she's the co-chair of the Health Network for Uninsured Clients. Shazeen will share practical strategies you can implement at an individual and organizational level to improve access to health services for uninsured clients. Then we'll expand our focus and think about provincial and policy and structural change. So from the Healthcare for All campaign, we have Nisha Kansal, who is a family physician at the Immigrant Women's Health Center and a locum family doctor at community health centers. And we have Kara Hansel, who is a family physician at the East End Community Health Center. And they'll share about the campaign, why it's so important, and how you can get involved. And then we'll have time for questions. And as we begin, I want to share this slide from the Health Network for Uninsured Clients because it really guides all our work. So we are committed to the right to health for everyone. And while we are all working at different organizations and from different angles, we have a deep shared commitment to access to health services and the broader conditions needed to be healthy, regardless of immigration status. And we know that working together is the only way to make that happen. All right, so let's get started with some key terms. I've used this term many times already. So uninsured is an umbrella term that refers to people who do not have publicly funded health insurance coverage. So in Ontario, that's the Ontario Health Insurance Plan, or OHIP. Now, the main reason why people are uninsured in Canada is because of their immigration status. And that's because governments have made this decision to tie status to health care coverage, even though it doesn't have to be that way. So in Canada, we have this two-tier immigration system where some people arrive in Canada with permanent resident status, with a right to live and work and study in Canada, while a large portion of people arrive with temporary resident status, so a work and study permit or visitor visa without full rights. So people growing our food, building our homes, caring for seniors, paying taxes without full rights. So if someone is a temporary resident, they may not have OHIP. So international students and visitors in Ontario are ineligible. Temporary foreign workers have to meet a number of criteria to be eligible, and in reality, it can be difficult to get a health card. Now, as a result of this two-tier immigration system, people can lose their status and become undocumented, and then they will be completely ineligible for OHIP currently. This denial of permanent resident status has profound implications for health. In addition to barriers to health services, which we're focused on today, migrants experience precarious and low-wage employment and inadequate hazardous housing conditions, food and income insecurity, and exclusion from social services. The roots of these health inequities are the laws and policies that deny permanent resident status and full rights to migrants, and the racism and xenophobia and anti-migrant sentiment that props up these laws. All right, so let's focus on health services. In Ontario, if you're uninsured, there is no universal access to health care unless you pay out of pocket. There are some really important pathways to free healthcare services that exist in Ontario, and some of them are really unique to the province. So there are 75 community health centers that provide primary healthcare and health promotion services, and people without health cards can access them, and the providers are salaried, so they're not billing to OHIP. Also, registered midwives are funded to see uninsured people who live in their catchment areas. They can also cover consults and diagnostics. There are some limited community clinics. They're often volunteer, donation, and partnership based. And then in theory, public health services offered by public health units should be accessible, but there's not that much information and access can vary. And then from March 2020 to March 2023, the Physician and Hospital Services for Uninsured Persons funding was introduced by the Ministry of Health for Ontario, and it covered medically necessary services in hospitals and select physician services in community for everyone living in Ontario who are uninsured. So this was historic and had a really positive impact. Conversely, a really negative impact when it was cut. So in the literature, the barriers that exist to health services are pretty common sense. Migrants face barriers because of cost, but also fear of those costs. They also fear that healthcare providers and institutions will share their confidential personal information. And finally, they do sometimes face exclusionary provider ideology. So xenophobic, racist, religious prejudice, and discrimination is documented in the literature and results in unwillingness to provide care, inadequate care, exclusionary practices, and stigmatizing or culturally unsafe treatment for migrants. We do have some evidence from the literature that migrants lack timely and streamlined access to COVID-19 services, assessment, vaccination, and treatment. So for example, while the Public Health Agency of Canada stated that vaccines would be available to people without status, provincial policies still impose barriers. So in Ontario, you needed a health card to book your vaccine appointment online. And so kind of the system was exclusionary by design. And then there was all these other workarounds that had to be developed so that people without a health card could get a vaccine. And there was really tremendous work done by many different partners to create lower barrier clinics where people weren't asked for ID or a mailing address or a health card. And so a lot of work had to be done. All right. So uninsured migrants are less likely to access primary health care, prenatal care, emergency care, and medication. When they do, they experience lower quality of care, including reduced continuity of care, tests, referrals, and follow-ups. And ultimately, they experience avoidable illness, injury, and death. As an example, there's a study of all emergency department visits in Ontario, which found that people who were uninsured arrived with more serious health conditions. They were more likely to leave untreated, and they were more likely to die. The same study found that for uninsured children and youth, they had higher visits for ambulatory care sensitive conditions like asthma. So this really indicates conditions that could have been better treated earlier through primary care. And I wanted to share this story. I've shared it a number of times about what this really means for individuals and families. This is from our podcast with Chloe Sabrone sharing her work at Médecins du Monde Canada in Montreal. So a bit about the Quebec context there. And Chloe is speaking about an uninsured little girl who has a cyst in her mouth. And she said, we had a little girl like this, and she had this cyst that she was trying to get removed for several months. Instead of solving that little issue that was not inexpensive, complicating surgery, we were having a little girl that was having a developmental issues in terms of language and also inclusion at school. So these health outcomes, impacts on early childhood development and inclusion are predictable and avoidable. We know what children need to thrive. We know what workers need to be safe. We know the importance of preventative healthcare and public health services, but we've made decisions to exclude migrants living in Canada from these essential determinants. So in the issue brief, we highlight a number of different actions to advance migrant health and justice from the literature, but also from the World Health Organization and migrant-led organization. And there's really like a triangulation there. Some really strong recommendations. I'll just dive right into them. So the first is that for public health and healthcare folks, you can make sure that your services and interventions and organizations are accessible to all people, regardless of their status or health card coverage. So this can include auditing your programs and removing requirements for IDs, health cards, status, and even mailing address. Training staff about this, about why it's important, clearly communicating in multiple languages, building trusting relationships with migrant-led groups, and developing targeted programs and outreach to meet the needs of migrants. I'm going to get Nisha to jump in briefly and share a really promising example of just this.
Thanks, Rebecca. Yes, I just wanted to briefly share about the main clinic that I work at, the Immigrant Women's Health Center in Toronto. It's a sexual health, public health clinic, but specifically a contracted clinic of public health that focuses on providing care to uninsured patients. And from what I understand, has existed since 1975. I have worked there for the last couple of years, which has been a great experience. Many of the different aspects that were mentioned by Rebecca are used already here in this clinic. So we wanted to just put this out as an example of a clinic that is accessible to uninsured clients. The clinic tries to keep on top of different trends in immigration to Canada so that they can best serve the needs of new populations. They are able to outreach appropriately and then have the needed language services available. So for example, at the moment, also based on the counselors that are available at the clinic, we have a lot of Spanish and Portuguese speaking patients, but I know in the past there have been sort of different waves, like a lot of Vietnamese speaking patients, for example, when that wave was a little bit more relevant, perhaps to new migrants that were coming in. The staff is also trained on providing care to people without health insurance, and it's a culturally safe and accessible clinic in that way. So the clients are identified by an IWHC clinic number rather than their OHIP card number. And as a contracted clinic of public health, the clinic receives funds for clinic operations through public health. And they're given certain OHIP codes for sexual health that they're allowed to use to bill OHIP through a no-card private billing system. So patients that come to IWHC who are uninsured generally do not have to pay for sexual health services. So we just wanted to give that as a brief example of one clinic that is providing care for uninsured people in Toronto and Ontario. We know also about, the TB Up program is another way that that's being done for uninsured persons. So there are examples where this exists already. We just wanted to share that as there are ways to get it to do it.
Brilliant. Thank you for those really tangible examples. One more slide from me. Yes, I'm unmuted. All right, so the other big role which we'll be talking about today is healthy public policy. So public health folks and healthcare folks really can advocate for healthy public policy, and there's been a lot of success, for example, in getting temporary paid sick days in Ontario. And so some two really important policies we'll talk about today are, of course, universal health care for all, but also permanent resident status for all. And so that really gets at the root, right? So that everyone who gets here comes to Canada should have permanent resident status on arrival. And I wanted to highlight the Migrant Workers Alliance for Change, which is a membership-based migrant-led organization that supports migrants across Canada in accessing basic rights and services. So if you're working to make your program or organization more accessible to migrants, MWAC is a great place to go. They are available for advice, meetings, trainings, and consultations. And they're also organizing to advance migrant health and justice. So you can stay up to date and support their migrant advocacy priorities by signing up for their latest petition. And Carolyn will add that to the chat. Okay, with that, I am going to hand it over to Shazeen.
Thank you, Rebecca and Nisha, for laying that super important groundwork. My name is Shazeen Suleiman. I am a midwife in the city of Toronto with a program called Match out of the South Riverdale Community Health Centre. I also co-chair the Health Network for Uninsured Clients. Oh, you guys are amazing. So we've got this Slido up. Again, in an effort to get a sense of who is in the room, we'd love to know what proportion of patients or clients that you work with that don't have access to provincial health insurance or who are uninsured. And you're already filling it in. This is amazing. Great. Just a couple more seconds. So there's a small portion of you who don't see any uninsured clients, but a significant number of you that do. Almost a third of you whose population base is over 50%. So we've got a lot of experts in the room. It's really good to know. Probably over to the next slide, Rebecca. Thank you. So I wanted to kind of just take a minute to tell you a little bit about the Health Network for Uninsured Clients, or the HNUC. So we, as a network, have been around for about 20 years now, with the goal to improve healthcare access for people living in Ontario without provincial health insurance. Some of you may already know about us. Some of you I see from the participant list are actually members of the HNUC. Thank you so much for coming. It's lovely to have you here. For those of you who are new to the network, we are a network of advocates who are calling, as I said, for equitable access to care for everyone, regardless of their health insurance or their immigration status. Our members are not uninsured people themselves, but those who work with uninsured clients or patients. Oh, a little note that the QR code does not work. Okay, I think we've got hnuc.org is the website, and I think that it'll be put in the chat. As far as our membership goes, we've got a pretty broad range of organizations who are the membership, including community health centers, some hospitals in Toronto. We've got shelters, legal clinics, people in public health, settlement services, research organizations, and a bunch of others. And it's really like the breadth of that membership that is what brings like such a unique perspective to the work. We've got our ears to the ground in a really unique way just because of who is our members. The network, its history is really a Toronto-focused network, but what we're finding is that our reach really expands well beyond Toronto across the province of Ontario, which I think really reflects how much people are on the move, especially now. If you are interested in this kind of work and you are in Ontario, I welcome you to join the network. If you head over to the website, hnuc.org, on the top right-hand corner of every page is a Join Us button. You can click there. Even if you don't want to join, I'd say for the sake of this presentation, head over to that website because we're going to be referring to it over the course of the presentation. Next slide, please. So we've got another Slido here. We've seen now already in this room, there are lots of folks with expertise in serving people that don't have health insurance. We want to hear from you. What are you seeing as the main kind of healthcare issues with this patient population in your organization? Take a second to type your response in. Mm. abortion access. I'm imagining access to primary care. Uh, a few here, a few around hospitals, and I imagine billing. Yeah, a lot of good crossover here. Sexual reproductive health care, finding primary care is coming up over and over again. Delivering, which I imagine means pregnancy and birth care. Yeah. Testing has come up, medications has come up. I love Slido for the fact that it will highlight the ones that are most common. Excellent. Thank you so much. Maybe we'll give it just a few more seconds. I can see a few people are still typing. Specialists not accepting. Yeah. Vaccine access. In the chat, we have someone typing in referrals to specialists like gynae. That's great. Thank you. Only because we're tight for time, I might move us on. But if you are typing, still go ahead and you can stick that in, and that we'll be able to capture what you're seeing as well. Rebecca, if you can, that's great. Thank you. So part of how we keep our ears to the ground at the network is that we, as I said, our membership are all people that work with migrants or people without health insurance. We also run a listserv at the HNUC and have a dedicated email address where people can write us in, our members can write us in with things that they are seeing or the kind of issues they need some one-on-one support with. And we keep track of all the cases that come through and annually review them. So we're soon going to be reviewing the cases for 2025. But I thought I'd share what we saw in 2024. I'll say we fielded over it was 121 cases. And of those cases, pregnancy care and hospital billing rang in at the kind of the two most commonly referred to issues. We also continue to see issues around newborn access to OHIP, which is our provincial health insurance, and challenges navigating community services. In that gray, the other box, it's a bunch of other issues, including medication coverage, lab coverage, access to palliative care, housing, dental coverage, chiropody. And in 2024, we saw a distinct increase in the requests for help with cancer care navigation. And I think that's going to come up again and when we do our 2025 numbers. But our pie chart looks very similar to the last slide and to similar to what you all are seeing out there across the country. Next slide, please. So our goal today is to leave you with some practical strategies to use when you're working with people without health insurance. The first step is really to kind of learn the system. As Rebecca has highlighted, in Canada, immigration status really determines your healthcare coverage. Some people living here without health insurance may have some form of private insurance, like, for example, international students. But most often, there are coverage gaps that are important to be aware of when you're taking these patients into care. I see this quite often in my work, where pregnancy is very often considered a pre-existing medical condition and so precludes people from accessing that really important care. Um, our immigration system is incredibly nuanced and I'll say constantly changing. And because of the tie between immigration and healthcare, it is very helpful to keep your pulse on what's happening in the immigration landscape. For example, kind of keeping in this current moment an eye for what's happening with Bill C-12. We really recommend kind of finding others who are doing this work as well and kind of joining other organizations that are doing the work to lend your energy, but also to be energized by others that are doing this because it is very challenging work. I'll say the HNUC website, I told you I was going to refer you back. On the top, we have two tabs that are called the need and the system, where we kind of break down some of the connections between immigration and healthcare. So it's a good spot to kind of go and learn a little bit more about the issue. So bookmark it, read through it later, I think you'll get some good tools there on becoming an effective advocate. Next slide, please. Working within your organization to facilitate access to care is also really important. From that human rights-based framework that Rebecca talked to us about, really take a look at who is getting access to care at your organization. And that means reviewing everything from your intake criteria onwards to make sure you are building kind of a low barrier service to catch these people that are often going to fall through the cracks. I'd recommend kind of building a filter in system rather than a filter out. So you're proactively including, seeking out, having an outreach strategy to reach people without health insurance, including those that are underinsured, those that are kind of here and as long-term visitors or who become residents. Um, it's also important to kind of look at the training of your staff, people, your frontline workers, the clerical staff, the healthcare service providers, and also the leadership, so that you have a consistent and welcoming experience for patients in light of what Rebecca's shared with us around the fear that often people will have in trying to access care. Mapping and leveraging the local resources in your area is also really vital. So know the community groups, the settlement services, the legal aid services, the faith networks, and also kind of the informal networks that might exist in your area. We found this to be very effective, kind of advocating for the change that you want to see within your organization by using data and storytelling from your day-to-day practice to influence your organization's policies, its budgets, and strategic priorities. To help with this, we've got an image on this slide of 2 reports that we've produced at the HNUC, 2 Steps Back and A Bridge to Universal Health. And we've found that many organizations have found these as a helpful evidence base when they're trying to craft a strategy for themselves. So please go ahead and take a look at those reports as well. Next slide. Some of this advocacy also needs to happen on a one-on-one basis with your clients or patients. So knowing, again, the local access points, we found providers, they like create tip sheets for themselves that they can pull out over the course of a clinical visit. For those of you who are in Ontario, the HNUC website, again, if you go to the healthcare services tab there, we've kind of gathered as many of the access points that we know of. They are fairly Toronto specific, but some of them do span the province. That section of the site is constantly updated. And it's translatable and printable. So again, like knowing the resources that are around, having them printer ready, so you can kind of when people come to your clinic, they can leave with something in hand as far as other pathways to care. Navigating hospital billing, we saw that come up just now on the slide. It was a really a kind of a key issue, and I'd say it's become much more so the case even post-COVID in Ontario. If your clients are getting bills, kind of work with them to the extent that you can for them to be able to request an itemized invoice for the care that they receive rather than kind of a block fee. So it's clear what they are being charged for. And really see to it that they're being charged the resident rate at the hospital and not the non-resident or visitor rate, which we know to be often it can be kind of double or triple the rate of a resident. Some hospitals have compassionate care policies, so it's good to kind of check in to see if something like that does exist, where a lower rate can be ascribed to the patient. And some of these policies will stipulate that there are payment plan options for people to slowly pay back what they owe. One of the things we found really helpful is accompaniment. So if you work within an organization where you have it within someone's job description to do accompaniment, that may be the patient care navigator or the social worker at your organization, we find it goes a long way for patients to bring somebody like that to the business office when they're trying to advocate for a lower fee. And just remember that these hospitals will often have a patient relations or ombudsperson office that can be leveraged. Like a letter can be written on behalf of the patient, or the patient can write themselves, and we found that to have some good effect as well. when you are supporting clients on this one-on-one basis, sorry, Rebecca, one more thing. Um, just a reminder to kind of use trauma-informed communication. Healthcare coverage, as we've talked about, is kind of tied to immigration status. And so asking about coverage sensitively is really important. Clients, these same clients are kind of more and more likely to kind of fall through their cracks. So if you are making referrals, doing that extra step to make sure that the connection's been made is really helpful. And if again, you do have access to supports like community workers or peers with lived experience who can be that bridge and accompany people or provide navigational support, that can really, really go a long way. Rebecca, I'm going to hand it back to you to tell us about the HNUC's newborn OHIP campaign, so we can see how some of this has been made IRL, how we made some of this come alive. Thanks, Rebecca.
Amazing. Thank you for all that rich knowledge, Shazeen. So yeah, we wanted to share a bit of information about an issue you might be seeing if you're working with uninsured clients. And that is that some newborns are not being registered for their health cards at birth in hospitals if their parents don't have OHIP or permanent status. Now, this isn't what should be happening. The Health Insurance Act in Ontario states 3 conditions. Newborns need to be born in Ontario. They need to be living here for 5 out of the next 12 months. And Ontario needs to be the primary place of residence for one of their parents. So that's the place where they have connections and are primarily living. It doesn't have anything to do with their immigration status or health card. And the baby's eligibility isn't determined by the parent's OHIP or status. The baby is a citizen, and it's really important that they're getting the health card in a really timely way. And we have this special process, registration process in hospitals, so parents don't have to go to Service Ontario. The hospital staff should be providing the registration form to parents who then attest to those 3 conditions, and then they'll get a temporary health number for the child. They can access hospital care, well baby visits, vaccinations, but we're seeing a breakdown in implementation at some hospitals where they're refusing to give that registration form, particularly when a parent doesn't have OHIP. So this is really concerning. It leads to delayed care, financial stress, inequitable treatment. So HNUC has developed a suite of resources to help support better implementation. So there's a guide and a quick reference card. There was also a reporting tool where you can anonymously report if you are seeing denials, so we can better understand what's happening. And this is all really to help clarify what the eligibility is and make sure that newborns are being registered. So hnuc.org, resources, and then you can find this in the newborn section. If you're in hospital, you can use this to help clarify the eligibility. And if you're working outside hospital, you can share this with your colleagues in hospital, with families themselves. We know that a number of public health folks will be working with hospitals or with families, like Healthy Babies, Healthy Children program, public health nurses. So really encourage you to check out these resources. Okay, we have just a couple minutes in case there are questions relevant to Shazeen and I. So Shazeen, if you want to pop off, join us on camera. One that I saw in the chat, it's a really good question, which is, how do communities know how many people in their community are uninsured? And I would say the question is, it's unclear because the government doesn't count this population. But Shazeen, do you have any thoughts about that?
I know we in this space have long been using this number of 500,000 as our estimate of the number of people in the province who are uninsured, but I'll say that that's from so our best estimate, and that's a 2016 number. And so we don't have a very good sense because as a system, we use the OHIP number to track how many people are using healthcare services. But it's going to be by connecting with organizations in your area that you're going to get a felt sense of what that is, if not the empiric number.
Yeah, absolutely. I think that's why partnerships are so important with like the Migrant Workers Alliance for Change, people like the Health Network for Uninsured Clients. They're doing a lot of information gathering and have a real like finger on the pulse, which can help in the absence of data. Okay, how do parents demonstrate that newborns will be living in Ontario long enough to qualify for registration? So they don't need to prove anything. They just need to know that they'll be here, right? I think that's the simplest answer.
Yeah. Yeah, that's right. And I'll say like it was a positive policy change in 2009, which allowed for it to be kind of well, for one, that babies were not connected to their parents. A positive policy change wherein starting 2009, the parent didn't have to have a OIP in order for the baby to qualify. And so that registration was moved to the time of birth, and it's kind of a self-attestation. Like the parent is asked or signs off to say that they will be living here for 5 months of the next 12. And there is no, and actually the policy like stipulates that no documentation needs to be provided. So they shouldn't be asked anything beyond that.
Great. I'm seeing someone in the chat is saying they recently saw a baby was denied OHIP. The father had OHIP, but the hospital's policy is to mirror the mother. So I assume it's if the mother doesn't have OHIP, then the baby. So that is one of those examples where that is totally contrary to what the law is in Ontario and what the Ministry of Health policy is. But we're seeing that a lot. So again, that's why we have those resources to try and help clarify, and hopefully you can use those. I have a question here. I think Shazine, you could help with. If a hospital doesn't have a compassionate care policy, what is the alternative solution?
One is to the extent that you can compel your hospital to develop one. I know that that's like a different level of advocacy than what we see on a one-on-one, but I think it does work if you have any leverage within your OHT, for example, your Ontario Health Team, to be able to start something like that. And then on an individual basis, I would say kind of using some of those tools that we talked about. So making sure that patients are being charged the resident rate rather than visitor or non-resident. The itemized billing is really an important task because otherwise we see deposit structures that are really broad. $10,000 to get care, but it's not explained what kind of care is covered. And then checking to see if there are payment plans. And it is a bit of a ground game in the absence of a policy where it will be up to that one-on-one kind of work that you can do with your patient. But those are the suggestions. If you go to the HNUC website, we have some strategies listed there too under the resources section.
Great. I was hoping you were going to say make those policies because I know you've been quite involved in developing some of those compassionate care policies. I have a question. Are there similar organizations in other provinces? I'm in BC. Do you have any suggestions about who I should connect with for similar supports? I don't know if any of the other panelists know. I think it's Sanctuary Health in BC, but I'm going to try and pull up their information and add it to the chat. Any other ideas? I think over the coming months too, I'm going to be trying to pull together some of these. If anyone knows, please add it to the chat of folks in other provinces doing good work. But I will be trying to get some of that information. What else? Could you clarify once more the resident rate as it relates to advocacy regarding hospital billing? Shazine?
So in this kind of universal healthcare system that we have, your provincial health insurance will cover if you have provincial health insurance, it'll cover both the facility fee, kind of the cost of what it is to seek care, use the facility, as well as the physician fee. If you don't have health insurance, hospitals in our province can set up their own billing mechanisms to charge patients that come in the door. both for the physician side of things, but also the facility fee. And that fee structure is, how do you say? It's like tiered. And so with a recognition for the fact that there will be people that actually do live here that don't have OHIP, there will be one set fee, and that's called the resident rate in most institutions, I find. And then below that, there's a non-resident or visitor rate for people that are here, say on a visitor visa, that is still active. And so it is worthwhile, especially for your patients that do live here, and frankly, even for those that don't, to try to advocate for the resident fee, is particularly if the fee is a barrier to accessing care.
Amazing. I see a lot of other questions. I'm not surprised. I think we're going to move along to Kara and Nisha's presentation. We will have some time at the end for questions, so you can add back your questions once we get there. And thank you so much to Shazeen. So maybe should we do this, Slido?
Maybe I can just, briefly say,
Yeah.
I know that we've been kind of talking about different strategies that people are using to improve access to health services for uninsured clients. If you have a second, maybe we'll spend like 30 seconds on this slide and people can put in ideas about specific strategies that they've been using to improve access to health services for their uninsured clients, whether they're a provider or working in a clinic serving clients or working in public health. Yeah, so working with community paramedicine programs, that's a great one. I know Shazeen already shared a couple as well about, if you have the capacity to be accompanying patients to hospital settings to advocate for them. Yeah, using funds from budgets to pay for medications, translation services, partnerships with other organizations, maybe migrant organizations that are doing this work. Yeah, midwives, CHCs, those are great as well. And in the chat, some people posted about IWHC. Anna, who I work with, my manager, I'm working very hard to get compassionate care from Women's College Hospital. I know that we do that a lot. Thank you. Yeah, so maybe moving to the next slide. So again, my name is Nisha, and Kara and I are coming today from the Healthcare for All campaign, which is under an organization called the Decent Work in Health Network. So the Healthcare for All campaign is being advanced by health workers like ourselves, community members, and migrant justice and health equity organizations that are fighting for migrant rights. Next slide. Our campaign again operates under the Decent Work and Health Network, who sees precarious work and lack of immigration status as health hazards, and we mobilize health workers in advocacy on these fronts. Next slide. So in discussing all of these different strategies that we have been already talking about to improve access to care for uninsured clients, Karen and I wanted to highlight the vital role of political advocacy in this as well. So the Healthcare for All campaign is focused on this and has two main demands of the Ontario government. First is to restore that PHSUP, or Physician and Hospital Services for Uninsured Persons program that Rebecca had mentioned, and not only restoring the program, but of course adequately implementing and creating awareness of the program so that it's actually able to be used appropriately. Secondly, and ultimately, we are asking for the extension of OHIP to all, including those without permanent resident status, but who live and work in Ontario. Only through extending OHIP to all do we feel we would actually be able to have universal health care. So that PHSCP program was implemented back in April 2020 when COVID hit. So the government did do the right thing at the time and recognized the importance of migrants in our community and our economy during the pandemic. But the program was also won because of over a decade of political advocacy on this issue by numerous folks in Ontario and across Canada, many of whom are probably in this room today. The program demonstrated why OHIP for All would be so beneficial for patients, healthcare providers, as well as our community at large. So by taking care of medical problems earlier and even being able to provide preventative care, that migrants usually wouldn't get, many devastating individual outcomes were prevented and downstream costs to the system were saved. In my family medicine practice, I see every day how the treatment of a simpler issue like hypertension, for example, or high blood pressure prevents a much more devastating outcome in the longer term, like a stroke or a heart attack, which causes significant loss of function, quality of life, and ability for somebody to work. Unfortunately, this quote unquote pandemic program was cut in March 2023, which left hundreds of thousands of people to suffer again. We know that the program, in fact, only costed $7.5 million per year out of a $70 billion healthcare budget. So, in our view, this is really a drop in the bucket for all the good that the program was able to do. Our healthcare system in general is underfunded, as we all know. And so we see these costs in a way being downloaded onto low-wage migrants who are paying for these services, like healthcare, through their taxes, but don't receive any of the benefits. Next slide. So ultimately, policy change is what we're asking for that would expand access to OHIP for all. Again, as a family doctor working in CHCs and working with uninsured clients in other settings, every day I find myself battling this patchwork system to care for my uninsured clients. Though the number of uninsured clients I have are not even that numerous, these battles can really consume all of my capacity. And this again is with working in a CHC where we have any sort of resources to serve these patients at all, including coverage for provider fees, diagnostic testing, and imaging. There's this myth that CHCs can provide any and all care to uninsured patients in Ontario. But again, beyond what I just listed, provider fees, diagnostic testing, imaging, blood work, that kind of thing, we are not actually able to cover any sort of hospital care or any kind of treatments, medications. Say somebody has cancer and needing chemotherapy. We don't have any funding for any of that. So I'm constantly trying to find particularly sympathetic specialists outside of the hospital setting specifically so that people aren't getting these facility fees, specialists that will see these patients and might be well versed themselves in navigating the system for uninsured patients. I'm also always hoping they're not going to be judgmental of my patient's immigration situation and that they're going to be able to support them rather than putting their own judgments and biases onto the situation. The responsibility for maintaining these good relationships with sympathetic specialists and hospitals ends up disproportionately falling to social workers, MDs, and NPs at our CHCs. And the burden of navigating the system causes so much burnout in these providers, causing them to one day just be unable to continue with doing it. So I really feel like this current system of patchwork coverage, even separate programs, especially for covering uninsured patients and things like that, is ultimately not sustainable or equitable in this regard. It's confusing, it's burdensome for patients and providers alike. And as a provider, I see this as a significant part of why a system that covers all living and working in Ontario, regardless of immigration status, is needed. Next slide. And as people and organizations providing care to the uninsured, I think we all in this room are the best poised to be advocates for this wholesome, universal healthcare system. Health workers have been able to bring about change already through sharing their stories and experiences in the media, supporting with research, using our expertise to advance equitable health policy by speaking directly to decision makers. Our organizing around uninsured care has used all of these strategies as well successfully to get the care needed for uninsured patients. Next slide. Maybe I'll pass it on to Kara. Thanks.
Okay, perfect. So far we've talked a little bit about what are some of the healthcare access gaps in our system, which clients are being most affected, and why it's so important to actually win a truly universal healthcare system in Ontario. And now we're going to pivot and talk a little bit more about how we envision actually doing this. And we want to first draw your attention to some of the policy openings that we have. And we just want to highlight these are openings that have been made through ongoing advocacy from a whole bunch of different organizations, including migrant rights groups, healthcare organizations. And so there's a couple of exciting developments. First is that the Ontario Hospital Association has actually put together a committee and has put out a statement recommending a program similar to the Physician Health Services for Uninsured Persons program to really close the gaps. And so we're hopeful that as other organizations put out similar statements, it enables us to really pressure our provincial government to put that into action. Secondly, the Health Minister of Ontario, Sylvia Jones, actually said publicly last year that no one will be charged for emergency services in an Ontario hospital. This is actually not true. Unfortunately, we're seeing time and time again, and I'm sure Shazeen could describe tons of stories of this, but people are absolutely being charged for emergency services in Ontario hospitals. You can see on the side there, that's the quote from the article. But what this does is it allows us to continue the conversation with the provincial government to really hold them accountable for that statement so that we can turn that statement into a reality. Next slide. So I'd like to take a moment just to ask you, what does political advocacy mean to you? I know it's a big question, but as we'll kind of break down, there's lots of different ways of approaching it and lots of different strategies that we can use. So I'm starting to see a few speaking up for what is right. Institutions, prioritizing, making changes, comment about equity, joining others who are fighting. So really kind of focusing on the collective aspect of it, talking to politicians, writing advocacy letters, seeing equity as kind of being a really big theme here. Oh, it's a word cloud. Sorry, everyone. I said it was a free text. But you're all responding, so thanks so much. Okay, I'll give it just another few moments. I know a couple folks are still typing. Influencing health policy, creating policy change in the government. Okay, perfect. I think we can move on to the next slide. Thanks, everyone. And so absolutely, you know, I think that we think of policy change as a really kind of big thing. But I want to really kind of talk about how we can break that down. And it can feel really hard to make a policy change. It sounds like a number of people in this webinar have some experience working with uninsured folks. And so you know kind of some of the problems that you and they may face on a regular basis. But, you know, just even highlighting the physician health services for uninsured program, that was something that came about through significant advocacy, which really shows us that there is a way forward and there are things that we can do. And so even though it feels really hard to make these changes, I want to highlight now a couple of things that we can do. And so the first is really building pressure inside your institution. We've all learned a lot today about why people are uninsured and some of the system challenges. And again, it sounds like a lot of you also bring your own expertise as well to this. And so one thing that can be really helpful is sharing this within your institution. Now, Shazeen talked more about this from the perspective of making specific policy changes within your institution for uninsured folks. But I think we can do something similar in terms of supporting a broader campaign that will actually bring about healthcare that's truly universal. And so that could look like sharing stories within your organization. As you'll see in a future slide, we do also have videos that our campaign has put together that you can share. And then you can also identify health champions within your organization. And that might even be you, but that could be someone who can really share this issue with others, build confidence to advance this work. And then you could even pass a resolution in your union or professional association. Another way that we can all make change is creating dialogue with policymakers. So that can look like, as some of you said in the last question, that could look like meeting with your MPPs or other staff in the Ministry of Health, and then sharing research and reports with policymakers. And so to flag the HNUC website again, there are 2 reports on there that can be really helpful to share. And if you're someone who's thinking, you know, you're not feeling very comfortable speaking with your MPP, we do actually have some resources as well for training for that to make you feel more comfortable and more prepared for something like that. And then finally, we encourage you to think about things outside of your work organization, about other communities or organizations that you're part of outside of work and how you can engage people in those contexts in this issue. Next slide. So given that again, it really takes everyone's actions to bring about the pressure that we need to cause a policy change and to win truly universal access to healthcare. What is something that you'd like to share with your colleagues, or you think you could share with your organization about improving access to health services for uninsured clients? I think, the topic of advocacy can, as I said, feel really big. And so just even realizing that when you share videos about this issue with someone in your organization, you are advancing the cause, helping more people to understand the issue. And ultimately, it's because so many people care about this issue that the Physician Health Services Uninsured program even started in the first place. And so we can do it again, and we need your help. Building community partnerships. Oh, sorry. Promoting access, investing early prevents downstream costs. So that's a helpful argument to make too when you're chatting with people about this issue. And viewing uninsured clients as humans, I think, we started off with Rebecca kind of acknowledging just the human rights kind of really basic aspect of this issue. And focusing on chronic underfunding versus expecting vulnerable populations to carry that burden. Yeah, so a lot of really good ideas about how you can frame these discussions with your colleagues. Okay. Perfect. Maybe we'll move on to the next slide. So lastly, we just wanted to share some of the tools that we've created. You can use this QR code here, and that will take you to our petition to support OHIP for All. And then we also, on our website, we also have some other resources that might be helpful. So as I said, how to have an effective conversation, which could be with your colleagues, for example, about this issue, how to present evidence to your MPP. And then we also have a fact sheet as well about why Ontario needs healthcare for all. And so these are some of, this is how you can reach us. And I would really encourage you just to take a look at our open letter. Because as I said, the more support we have, the better. And I think I'll turn it back to Rebecca now.
Thank you. I'm just coming off video. There we go. Thank you so much, Kara, Nisha, Shazeen, for sharing about advocating at the individual level in your organization, and then some really tangible ways we can tap into this bigger provincial policy advocacy. And I really appreciate all the comments and questions in the chat box too. I just want to highlight, someone did share in BC. Many of us are part of a coalition called Access Without Fear. And there's a few clinics in the Metro Van area that are able to provide services to uninsured. So I asked that question and it was answered. So thank you so much. Access Without Fear for folks in BC. If my other panelists want to come on video, we have 10 minutes for questions. I'd encourage everyone to put their questions in the Q&A box. And I just want to do a little bit of housekeeping as you do that. So please connect with us at NCCDH and with the campaign. Our website is here, email, social media, our mailing list. And please fill out the short evaluation survey that Carolyn will put in the chat to provide feedback for all of us for today's webinar. And I'd love if you thought about, are there any other resources, webinars, advocacy tools that would help you with advancing migrant health? And you can put those in the evaluation too. And we'll all be thinking about what more we can do in this space. So I'm going to stop sharing the slideshow so that we can do some questions. Okay. So what are some questions we have? There's a question about how do you justify costs to taxpayers I see the benefits for our communities, but I have to deal with public concern about monies that could be placed elsewhere that are a priority. Oh, I will unshare my screen too. But yeah, maybe someone from the campaign, Nisha, Kara.
Yeah, I think the main thing, this question comes up all the time. It's one of the, number one questions that people are asking when we're talking about expanding access or, putting in funding towards any sort of service. We're always asking about where is the money coming from? I think the most important thing that we always focus on is about the prevention of downstream costs. So I think I talked a little bit about that, the cost of creating access to see a family physician to monitor blood pressure like on a regular basis with screening, catching high blood pressure early on and treating that for somebody rather than having them, not being seen in primary care, not receiving that preventive care, one day ending up with a terrible, devastating outcome like a stroke or a heart attack, which are things that we see every day, right, in primary care or working in hospital settings of people who didn't have well-treated risk factors and then end up with devastating outcomes, which then costs infinitely more to the hospital system when that person needs essential care in the emergency department with emergency room doctors and nurses and all the medications and resources that are required in the emergency setting. And then this patient gets admitted and the thousands and thousands of dollars it costs to care for a patient who's had a stroke in a hospital involving physicians, nurses, occupational therapists, physiotherapists, dietitians, SLP, like there's so many different resources that end up getting involved. And then to that person, the devastation to their quality of life and their ability to work in the long term, right? These are all of those downstream costs that we talk about preventing by treating this person early on and adequately providing them that preventive care and medications to treat a small problem before it becomes big. Those are the kind of concepts that we tend to focus on when this question comes up, as well in conjunction with the fact that health and healthcare is a human right. We pull that from the like global bodies like the WHO in terms of the provision of healthcare to all. So yeah, those are the kinds of things that I think about. I don't know if Kara or anybody else wants to mention other points.
Yeah, I would just add that, during the pandemic, we actually did have a program that was doing this, and it seems that it wasn't particularly costly. So I agree with Nisha. I think we do think a lot more about like just what are the prevention issues and how could we actually save money by providing this care, but we are most oriented in the fact that this is a human right. But if we do want to think about this more from a financial perspective, we know that it was actually feasible. So that's one important thing. Like we've actually done it now, and so we're just really asking to restart it. It's something we know can be done from a financial perspective. And then the other thing I would just say, just because I think the question was about justifying costs to taxpayers, but as we mentioned, people who are uninsured and undocumented are in fact like any purchase that they make involves taxes as well, right? And so they are actually a taxpayer as well, and they're not getting the healthcare services that they're actually helping to fund as well.
Wonderful. Let me ask a couple more questions. And I'm going to ask a couple, and then if you have an answer, you can raise your hand. So first, how are folks navigating the intersection of lack of access, but also anti-Palestinian racism for folks uninsured and affected by genocide in Gaza rising in Canada? Thank you so much for that question. We also have one, how can someone use OHIP or interim federal health program for back pay? So for, I guess, retroactive costs and how far back? And then are specialists legally allowed to decline referrals based on a patient's uninsured status? Anyone want to take one or many of those questions?
The specialist question, maybe I can take, though I'm not a specialist or someone who bills, but I do often send referrals to specialists. I think they can and do decline them. And they will set up, again, in this like system that is purportedly universal. There is a mechanism by which they can accept referrals on with the billing codes of the health insurance numbers of the patients that are being referred. But in the absence of a health insurance number, it's sort of their prerogative around if they take up those referrals and how they manage them. And so some will set up a fee structure for people that are seeking care, block fees, that sort of thing. And others, I will say, are really they work in the Ontario context. Community health centers, for example, have set up systems by which these providers can be paid, and they're charged. They bill at the Ontario the health insurance rate. But I think to your question, I think they can and do decline them.
Thanks, Shazeen.
Mm-hmm.
Does anyone know about OHIP back pay?
I've seen this at one of the hospitals that we'd connected with about compassionate care. And I think that hospital had said if a person acquires OHIP within 6 months of seeking care, they can get their fees back, which makes me think that there must be a mechanism, though I don't know it with a lot of certainty.
Okay, thank you. And I'll say regarding the question about anti-Palestinian racism that I think we see across uninsured populations that racism is really intertwined with the denials being seen, right? So anti-Black racism is at play, Islamophobia is at play, anti-Palestinian racism is at play. So I don't think I have a good answer, but just to acknowledge that that's very true. And Nisha, I see you've come off mute.
Yeah, I was
Go
just going to
ahead.
mention, I don't know if I have the specific answer myself either, but I am connected to people who have been doing work around this specifically, like trying to increase access and understand the barriers that are being faced by Palestinian people that are coming from Gaza during the current genocide. So if you were interested in being connected with them, if there was like a particular case of somebody that you were working with, the person that asked this question, or you wanted to be connected to people doing advocacy work on this, I don't know if there's like an email that can be given for people to contact us afterwards, and because I would love to connect you with the folks that I believe are doing work on that, specifically for Palestinians.
Okay, so I have I'll make sure to connect the person who asked that question. I see I'm getting kind of consent in the chat, so we can make sure we get that info. Let me see, just trying to keep track of questions. I think there's one more. Can you discuss the special temporary resident permit for victims of human trafficking? My impression is that it's hard to access and underused, but it does provide people with extensive health coverage and perhaps could be better promoted. Anyone familiar with that program? Temporary resident permit for victims of human trafficking. I think that might be a bit out of our depth, and I think that like really highlights how important it is that we're working with our colleagues in legal aid and with migrant rights organizations, social workers, who can kind of like knit together those gaps. Okay, we are right at the end. Anyone, Shazeen, Kara, Nisha, anything you wanted to add before we wrap up? Okay, I just want to thank you. Oh, Nisha, go ahead.
Sorry, I was just going to quickly mention about that last question. I'm not familiar with this particular program, but if somebody was looking for more information about this, I would assume maybe through like CCVT, like the Canadian Centre for Victims of Torture, maybe they are more familiar with this pathway and they use it more. So if somebody wanted to read more about that or get more information, probably CCVT.
Great. Okay. Thank you for all the reactions. Thank you, everyone. It's heartening to have so many people come to the webinar and be curious about learning more and sharing generously in the chat your ideas. I want to thank Nisha, Kara, and Shazine so much for being generous with your time and expertise today. And I think it should be clear that working together is better. It's so necessary in this work. I think it gives us hope and strategy. And so I urge you to connect with your colleagues, share something you've learned today, join HNUC, join the campaign, and get in touch if you have questions we couldn't answer. Okay, thank you so much, everyone. Take care.